Welcome. This is a recorded presentation by Dr. Alicia Boccellari from San Francisco's Trauma Recovery Center.
I'm going to start by just talking about underserved populations and traditional services that often victims get offered, and then I'll talk about the Trauma Recovery Center model. So I've been thinking about how this journey for me began. I have been a psychologist at San Francisco General Hospital for many years now. San Francisco General is a county hospital, and it's also a level 1 trauma center, which means all of the victims of violent crime and any serious injury end up at San Francisco General. And one of the surgeons, Bill Schechter, said to me one day, "We can sew them up, but we can't make them well." And really what he was referring to were the many young victims of shootings, the severe domestic violence cases, where there would be these amazing surgical interventions that ended up saving their lives. But when he would do follow-up with them a few months later, he ended up finding that so many of their lives had become broken. He was seeing people not being able to return to work. He was seeing families that were dealing with the devastating aftermath of the psychological effects of trauma. And so from that point, we decided we wanted to begin looking at providing services to that population. And I will tell you that we first began this project in about 1998, and I will tell you all of the mistakes I made along the way, because there really were many. And this model has been evolving over time, and I think there continues to be room for it to continue to evolve and be made better. But before I talk about the model itself, let me just review with you, and I know all of you, many of you are service providers, you know what the effects of violence are on the individual and on the community. But just to remind you, we know that 50% of people who are a victim of a violent crime really do suffer the devastating effects of trauma unless they're given some kind of timely and effective treatment. And some of those symptoms include anything from flashbacks, nightmares, intrusive thoughts about the trauma. We know that oftentimes people can spiral into not only post-traumatic stress disorder, but depression. People may become suicidal. They may become angry, frustrated. A whole host of phobias may develop. A particularly prominent one is the fear of leaving one's home to venture out into the community. We know that oftentimes substance abuse and alcohol end up getting activated as a way of people trying to medicate some of their symptoms. In the end, we know that people may have problems with disorganization, problems focusing their attention. We know that violence robs people of their sense of safety in the world. We know that violence disrupts people's lives and their relationships, and lives begin to unravel. And it really is the ripple effect, not only in the individual, but in the family and in the community in which they live. I'm going to start by presenting one of the clients that I had a chance to work with at the Trauma Recovery Center. So Vanessa is a 50-year-old African-American woman. Her 31-year-old daughter, her 18-year-old son, and her 3-year-old grandson were all shot during a drive-by shooting. The 31-year-old daughter was at a gas station pumping gas into her car with a van. She had an SUV filled with her kids and got caught in crossfire of a shooting that happened. And the 31-year-old daughter died. Her son, her 3-year-old son, died, and a grandson was left with serious injuries. So Vanessa was left raising her 6 grandchildren, as well as her own 3 children. Her son-in-law had recently died 6 months earlier, so she became the sole parental guardian for all of these kids. She needed to quit her job She'd worked as a part-time hairstylist and a security guard, and she needed to quit the job to take care of her expanded family of 3 children and 6 grandchildren. So when you think about these symptoms, someone who pretty much entire life has been shattered, and perhaps part of the working poor, without a whole lot of resources, without a support system, how does someone like this go about accessing help? Well, there are 2 scenarios we can look at. One is the usual care model offered by, every state has a victim compensation program or victim restitution fund where victims can apply to get access to some of these restitution funds, which may give them money for mental health services or funeral, burial expenses, lost wages, things like that. Or we can look at the Trauma Recovery Center model. So for the victim compensation model, there was a National Institute of Justice study that looked at data from California and 5 other states, and it found out that only 20% of crime victims were aware that these restitution funds existed. Only 4% of victims' needs were addressed by the current victim service system, and that ethnic and racial minorities had the highest amount of unmet needs. In a similar study, and this is kind of a very busy slide, but the bottom line is that the second bullet, 2 in 3 of crime victims had been victims of multiple crimes in the past 5 years. African American and Latinos are more likely to have been victims of 3 or more crimes in the past 5 years. And that the bottom bullet, 4 of 5 services available to crime victims were unknown to the majority of victims. For those who use the services, almost 50% had trouble accessing the services. In other words, those with the most need are often those that are least served. And let me just say something about polyvictimization, and one of the things that we have found in the folks we work with at TRC, which is similar to what Jacqueline was talking about. Many of the people, when they come to us, and we've looked at data on this, most of them have had, by the time they come to us, have had 5 previous histories of violent crime by the time they get to us. So we're really talking about polyvictimization. So let's say for Vanessa, she wants to get on victim restitution funds. In California, there's a lot that she would need to pull together, and I think this is probably true in most states where there's an application, a victim application that needs to be filled out. There needs to be a police report that gets filed, and in California, and I believe it's this way in most states, if you don't have a police report, you're not eligible for this restitution fund. And we know a lot of victims of violent crime, there are many reasons why they do not want to file a police report, so that becomes an immediate barrier to getting access to these funds. They may need to send in mental health records and medical records. They may need to have an employer send in information for lost wages. The list goes on and on and on. And again, think about, this is Vanessa, who can barely get out of bed in the morning. She is so overwhelmed with grief, and we are asking her to do all of this. And somehow she needs to figure out a way of getting all of this done. And maybe there is someone that is helping her put this information together, but maybe not. One of the things we looked at was the state of California did an audit on how long it was taking for victims of violent crime to access services. And one of the things they found was that 30% of the applications were taking more than 3 months to process, and 20% were taking more than 6 months to be paid. And the audit also showed there were 2,700 victims of crime in California that were waiting for more than 6 months to have their applications processed. And when you're thinking about someone like Vanessa, they don't have 3 months to wait for services. They don't have 6 months to wait for services. The need is right there, and there's an immediate need for that. So for Vanessa, immediately following the shooting, she was having flashbacks, nightmares, insomnia, panic attacks, fainting spells. She was fearful of driving her car. She lost 35 pounds. an increase in high blood pressure, worsening of her diabetes. She was afraid to have her children and grandchildren leave her house. This was a problem because the kids were not going to school. She was dealing with the overwhelming grief as well as the need to be strong for her family as her grandchildren and children all were grieving. She was acutely suicidal, but she made a commitment to live for her children and grandchildren. So when we're looking at the economic consequence of violence, if we're not so moved by the cost to the victim, if we just look at the economics of it, we know that untreated trauma results in a greater likelihood of engaging in high-risk health behaviors. We know that after trauma, smoking, alcohol, substance use, poor eating, and exercise habits end up happening. We know that victims of violence access health care 2 to 2.5 times more frequently than those without a history of violence. And we know that the cost to the healthcare system is $333 billion to $750 billion annually due to not only healthcare costs, but also people spiraling into things like bankruptcy. The annual cost to insurers, government programs due to lost productivity, lost revenues, reliance on government entitlements is $330 billion a year. And so when we begin thinking about, let's say a victim of a violent crime manages to get access to the Victim Restitution Fund, which now may enable them to go and see a fee-for-service mental health provider. We know that traditional psychotherapy for victims of crime tends to be office-based, no home visits, oftentimes may not offer practical assistance or coordination with other systems. It tends to be a 50-minute hour and tends to be feeling, insight, and disclosure oriented. So if you are if you did become eligible for Victim Restitution Fund, you would be given a traditional model like this, and it would not include anything like case management, it wouldn't include outreach, it wouldn't include anything but office-based treatment. So one of the things that we had hoped to do, I know this is a lofty vision, but I think now more than ever we need to be able to dream big dreams. Our vision is a community that heals the wounds of violence and embraces the hope for a nonviolent, compassionate world. And I say this because, if we don't put this out into the universe, if we really don't have that kind of dream or vision, I really feel we're lost. So this becomes, in some ways, the guiding light for us at the Trauma Recovery Center. So what we wanted to do was, let me tell. So we begin this pilot at San Francisco General. Dr. Schechter, we can sew them up, but we can't make them well. And it was an interesting idea because here we have a captive audience of people who are on hospital beds that are recovering from their beatings or their shootings. And we thought, what we'll do, we'll go to their bedside and we will offer them mental health services. And we were so mistaken by how we approached people. And thinking back on it, I should have known better. But I think, I think if we're open to our mistakes, it kind of helps us do better. So one of the things that we ended up, what do you think happened? When I would approach somebody at their bedside and say, "Hi, you've been shot. We'd like to help. We'd like to give you some mental health services." What do you think happened? You all probably know. I did not know at the time, but what do you think happened? So there was suspicion, right? And partly, there is such a stigma around mental health treatment. The response is, "What, do you think I'm crazy?" And they were right. There is a lot of times, I'm a psychologist, and so I feel like I can bash my own profession a little bit. And a lot of times, mental health people, the traditional mental health system tends to judge people, tends to diagnose them, and instead of asking people, "What happened to you?" it's "What's wrong with you?" So there's a lot of stigma around mental health services. That was number one. And number two, when people are in the throes of acute stress disorder or post-traumatic stress disorder, one of the main symptoms of it is avoidance. People do not want to talk about what happened because when they talk about it, the flashbacks begin. They begin having intrusive thoughts, so they just want to shut down. And yet, if you don't find a way to be able to bridge that gap with people, people can't get better. And so we were stymied. We had gotten, a little bit of foundation money to do this pilot. And it didn't matter if I had the most amazing banquet of services to offer people if we couldn't figure out how to engage people. And one of the things we also realized was that people had such practical needs. They had a need for safe housing. They had a need to help someone file police reports with them. They had a need for someone to go to the court if they were going to testify. They had all kinds of practical needs. And so one part of our model was an emphasis upon assertive tracking, outreach, and engagement into services. So what we began doing, getting back to the fact that so many people are afraid to leave their homes, so we would begin saying to them, we can help you. What do you need help with? And began giving them choices around practical assistance. And if you want to talk to us, we can do that as well. So engaging people in practical services. And we found that a lot of people could not come to us, so we began doing home visits and began providing services in their home and began doing assertive tracking. And by that, if people didn't come to us, we would go to them. If people missed their appointments, we would track them down. We have people sign consent forms that if you don't come in for treatment, that we can go and do a home visit. We actually, about 25% of our patients are homeless. We can take photographs of them and we can look for them on the street if need be. We began offering clinical case management to address basic needs of the medical, legal, financial, housing services, and evidence-based psychotherapy to target the distress and to increase their interpersonal safety. And I'll talk more about that in just a little bit. And so we've talked a little bit about this. Many victims feel ashamed about entering therapy and avoid trauma reminders. We work with them on what's most important to them, and we'll see them at the hospital, at their home, in the community, including homeless encampments, shelters, etc. The model has since evolved over time, where we continue to do sweeps at San Francisco General. The Trauma Recovery Center is located about 10 blocks away from the hospital, and we go on the medical units and we look for victims of violent crime. And obviously the hospital knows us well enough now that they also refer a lot of cases to us. But that's only one entry point into the Trauma Recovery Center. A Trauma Recovery Center does not have to be hospital-based, but it really is a good place to begin doing that initial work. We receive referrals from rape crisis centers, domestic violence shelters, from the police department, from the district attorney's office. There were 11 primary care clinics in San Francisco within the Department of Public Health. Primary care docs, when they identify victims of domestic violence, will also refer to us. So we try to catch as many victims as we can. So the goals were initially to streamline the eligibility process for victims, to identify additional barriers to accessing services, to develop a comprehensive, well-coordinated model of care that includes mental health, physical health, psychosocial services, and legal advocacy, to provide these services in a culturally competent and sensitive manner, and to evaluate this model to ensure that it's both treatment effective and cost effective. And this last point I think is really important. We work with such vulnerable people, and if I cannot demonstrate that what I'm doing with someone helps, then I shouldn't be doing it. And I really feel strongly about this. We need to be able to evaluate what we do, because the people we work with deserve it. And I think there's a big health disparity issue here, and that is a lot of times, again, the people who need the most services get the least services. And I also believe the health disparity in that people deserve evidence-based treatments. And by evidence-based treatment, what we mean is treatments that have been proven to work. And a lot of times that's not offered to poor people. Oftentimes poor people are not given evidence-based treatments. We had be grateful to the patients in some of these slides who so readily agreed to have their photographs taken. This was a gentleman who was in the emergency room being treated for a stab wound. This is the hand of one of my social workers, Stacy. She's doing a, quote, home visit from a homeless man who was living in a van. And so the case management, you know, I know a lot of people in this room have programs that do case management, and some of the things we offer are access to financial entitlements, whether that be general assistance, SSI, Medicaid, arrangement for stable, safe housing, linkage with medical care, taking people to appointments, taking people liaison with community-based agencies, connection with the district attorney's office, linkage to religious community. And I will tell you, so many of the people we see, particularly family members of homicide victims, where their church, their religion, prior to the murder of their child was really a source of comfort for them. And after you have a family member who has been murdered, you know, it shakes you to the very core. And the very thing that you often turn to, your religious community, oftentimes people end up feeling like, you know, why did God do this? And there really is a spiritual crisis that people go through. And one of the goals that we work with people on when they're ready is trying to link them back to their religion, to their church. And of course, assistance to return to work. I'm going to go through this pretty quickly. We want to decrease psychological and medical symptoms. We want to increase people's ability to work, to parent, to do daily living activities. We want to minimize long-term disability. We want to improve quality of life. We want to increase cooperation with law enforcement. We want to increase linkage to other entitlements, and we want clients to be satisfied with the services provided. So let me go back to Vanessa, what we offered her. As I mentioned, she was afraid to leave her home, and so we did frequent home visits. We provided mental health services, which I'll talk about in a little bit, trauma-focused therapy. When she was eventually able to leave her home, we do a support group for family members of homicide victims. She needed, eventually, she needed some medication to help with her nightmares and her sleep. We taught her grounding techniques, provided mental health services for her children and grandchildren, help in returning her children, grandchildren to school, connection to child care assistance, assistance with meals brought into the home, filing state disability, obtain Medi-Cal for the family, connection to primary care, got her into safer Section 8 housing, did a lot of legal advocacy with the police and the district attorney. Now, so Vanessa's daughter had an SUV, and that was impounded by the police for evidence. And they held on to the car for months. And Vanessa now has, you know, this huge family she's needing to transport, and she had like a small car. And one of the things that we try to do is, you know, it's not just about providing mental health services. It really is about developing a community of healing. And that community of healing extends beyond the four walls of TRC. And when you think about it, what does it take? What does it take to heal from something like this? Your daughter being murdered, your 3-year-old grandson in the hospital having been shot, and your 18-year-old son shot. How do you heal from something like that? And the reality of it is that this kind of violence makes people lose their sense of safety in the world. You lose all sense that the world is a safe place. And some of us are lucky enough that that is our worldview, that we believe that the world is relatively safe. But when that gets shaken, how do you go on? And for me, as a mental health provider, how do you help someone heal from that? And one of the things that I think is a basic tenet of the TRC is to really leverage whatever you can in the community, and to get local businesses to join forces and to come forth, and in this case, a car company in San Francisco gave Vanessa an SUV. And at Christmas time, we had a conference room this size. It was filled with toys and bicycles for the kids and the grandchildren. This is just one example. And we make a point of telling our clients, people do care about you. And, the world, yes, it can be filled with cruelty and violence, but there are also good, caring people. And and kind of restoring that sense, that worldview for people. So did fundraising for family, donation of clothes, gifts for children and grandchildren. We were able to get legal help, pro bono help, to speed up the process of her getting custody of all of her grandchildren, and we were able to eventually reconnect her to her church. 1 year later, decrease in flashbacks, nightmares, improved sleep. She was able to leave her house, drive her car, better managing her medical problems. We were able to move her to new housing outside of San Francisco, where it was in a safe community, a big backyard. Children can walk to school. She returned to work as a hairstylist, and she says, I can function again. I went to TRC crying out for help. The doors were open. They helped me find the strength to go on. So the team of people that provides this are social workers, psychologists, psychiatrists, nurse practitioners. We have a research team. We have psychology and social work interns and medical students. And over time, we've been able to increase our language capacity to a variety of languages. We see, when we talk about underserved populations, I'm including in that undocumented people, refugees, people of color living in violent communities, chronically mentally ill. So the mental health services, we provide a whole host of mental health services, crisis intervention, individual trauma-focused psychotherapy, which I'll talk about in a little bit, psychoeducation support, medication management. We offer a whole variety of groups. When we talk about evidence-based treatment, again, we're talking about treatment that research has shown works, and there's a whole variety of them. Cognitive behavioral therapy, DBT, seeking safety. One of the things that we strive for is, one of the things that is so encouraging about doing this work is really being able to bear witness to the kind of resiliency that people have. And when people can use something that's so horrific as a jumping off point to change their lives is nothing short of inspiring. And people can get to the point where they make positive meaning of the trauma. And they get to the point where it's not that they get over it, they will always have that with them, but they can somehow make something out of it. And some of our clients have gone on to use it as a way to go to City College or to do volunteer work, and we found our clients over and over again saying, we want to give back somehow. And one of the things we created, or our clients created, was CHAT, and that means Communities Healing and Transforming Trauma. And CHAT is made up of our TRC clients, former clients, and it is our speakers bureau. And we train our clients to do public speaking, and they go out and they go to local high schools, or they go to the police department, or they went to Stanford Law School a month ago to talk to law students about their experience with the judicial system and with criminal courts. And it serves actually, as an aside, they work with each other. There's a support group around these public speaking engagements, and it also is really not only a way for them to give back to the community, but it's also a way for them to speak truth to power. We've had them go and speak before the California State Senate and other kind of legislative bodies around the impact of trauma. This was a young woman who, when she was pregnant with her baby, was a victim of domestic violence. You can see the scar down the side of her face. She later went on to deliver a very healthy baby boy. So we had data before the Trauma Recovery Center on sexual assault victims, and found that only 6% of sexual assault victims were able to access mental health services. and after offering the trauma recovery services, it's gone up to 71%. So we've talked about this. Disadvantaged young victims less likely to file victim applications. Only a small number of victims receive mental health services. This is just, we did a randomized treatment trial where we put 1/3 of our survivors into usual care and 2/3 into trauma recovery center services, and found that only 28% engaged in usual care ended up getting access to victim services compared to 77% in TRC. I'm going to go through these pretty quickly. They're kind of boring. I could say homeless victims were less likely to file with usual care. TRC services eliminated this disparity. Younger victims were less likely to access services. TRC eliminated this. Only 38% of usual care access mental health services. 72% of those assigned to TRC got into services. In terms of what people said at the end of treatment, 93% said that treatment helped them feel better emotionally. 90% had improvements in relationships and family. 87% had improvements in dealing with alcohol and drug problems. 99% reported they were moderately to extremely satisfied, and 97% reported they would recommend the center to their family and friends. This is kind of a messy slide, but we wanted to look at, so are we cost effective? And on the, this is usual care. So these were people who got into victim compensation, traditional mental health services, and they were offered, 100% of the services were office-based. With the TRC, we offered not only office-based treatment, but all the clinical case management, individual group, family therapy, crisis intervention. We also offered all of this in terms of outreach and tracking, quality assurance, consultation to other providers. In the end, it turned out that we were 34% less costly. Unit cost was about $67 an hour as compared to the state's cost of about $102 an hour, or again, 34% less than fee-for-service. So we also looked at 261 consecutive patients that we treated at the Trauma Recovery Center. And we give people a measure of post-traumatic stress disorder, and this dotted line here, anything above that, people meet the diagnostic criteria for PTSD, which is a whole host of different symptoms. And we measured it at intake here at the beginning of treatment, and virtually all 261 people met the official diagnosis for PTSD. And by the end of the 16th session, significantly dropped, where symptoms decreased by 38% between the beginning of treatment and by session 16. And when you look at it, it turns out 88% of the people we served ended up no longer meeting criteria for PTSD. And about 12% continue to meet the diagnosis, and of course those would be people we would continue to treat. When we looked at depression, so that dotted line is probable diagnosis of depression, and again, majority of all of these people met criteria for depression, and by session 16 there was a 52% decrease in depression. Now, sleep is a really, really big issue, and it becomes, most of the people we see end up having insomnia, or they sleep and they wake up with horrible nightmares. And if you can imagine the havoc that plays on your life. I mean, I go one night not sleeping well, and I can't think the next day. I'm a basket case. And if you can imagine what that's like day after day after day, where people can't focus, they can't think correctly, they make poor decisions. So sleep really needs to be an important target of getting people healthy again. You know, sleep quality improved by about 20%. A lot of the folks we see are in physical pain related to having been shot or stabbed. That decreased by about 12%. I don't know what we're doing to improve, I don't know what else we can do to improve that. I think that is an area that we can probably figure out a better intervention for. Overall quality of life increased by 16%. I'm going to go through these pretty quickly. So we were at this for a really, really long time, and Senator Leno in California became interested in our model, and he was able in 2014 to have the state of California replicate the Trauma Recovery Center. And in 2014, in addition to San Francisco, TRC was created in Long Beach and Los Angeles. And then, this says Cat having worked really hard to get somewhere and then wondering where it is they really got. And this is sometimes, how you feel, you work really hard at something, and I was so ecstatic that there were going to be more TRCs in California, only to find out that unlike Illinois, which is doing things the right way, looking at things strategically and really being data-driven and looking at how to do things, when California began rolling out the TRCs, they did it without a whole lot of attention to what that implementation plan was going to be. And then in January 2015, the state of California passed Prop 47, and this is a really interesting ballot. What they did was they ended up decriminalizing certain victimless crimes, like some of the, instead of felony drug charges, reduced it to misdemeanors, and by not putting people in prison, they were saving the correctional system a lot of money, and they decided to take 65% of the money they were saving and put it into drug and alcohol diversion programs. 25% of the money was given to school districts to identify PTSD in young children in the school, and 10% was to fund trauma recovery centers throughout California. So this was an expansion of the TRCs. So right now there are 11 in California, 5 opened in Ohio in January, and Michigan hopes to open several more in October. Again, we talked already a little bit about evidence-based practices, about the importance of using practices that we know work. Evidence-based practices are developed through research. They're interventions that have been shown to work. They're consistent with evidence showing that the intervention can improve client outcomes.